Week 6, halfway through. We're almost there, guys. You've done the brunt of the work so far. I'm warning you, it's going to get pretty rough in the next 2 weeks. Remember, you have projects due in community, you have projects due in peds, you have exams coming up, med-surg exams. It's getting busy. I know, I know. One thing at a time. So every day, do just a little bit. As I said, with those projects, make sure you get them in early to me. I can help you get your best grades possible. All right. And I'll give you maybe that template for future papers that you can have, because I will figure it out for you and I will send it back to you so that you're a step ahead. All right. We won't go into there any further. Today, what are we going to do? We're going to do hematological, immunological, and children with cancer. So there's key things there. So let's do the PowerPoint. Remember, at any time you're not understanding, just stop me, ask me my questions. So hematological, immunological dysfunction. So when you think of hematology, immunology, you're thinking of immune system and you're thinking of blood, right? So how do we go and we look at these things and evaluate, assess it? So anything that has to do with blood is a simple CBC. Now, a CBC tells you a lot of information. White blood cells elevated, showing you have an infection. If they're normal, that means that infection is a viral, and that means you're not going to have elevated white counts. Also, white counts can show you leukemia, right? So it can show you no white cells, and it can show you that enraging infection, white blood cells. Also, hemoglobin hematocrit. How much oxygen and iron are in your body? How much energy do I have? And then the other one is platelets. Platelets have to do with bleeding. If you have low platelets, you're going to bleed because it's part of that thing that you need to stop blood from bleeding, okay? So as we're going through, we doing that CBC and looking at all those components, we're also going to be asking questions. Now, the most common of all hematological dysfunction is iron deficiency anemia. And what would you see? Well, iron deficiency, that means low iron. What does iron do to the body? It gives you energy, right? Gives you that get up and go that you need. So if you don't have iron in your body, you're not going to have that. And you're going to see a child that's going to be tiring easily, unusually, like they're usually up and out and moving all over the place, right? We also know that toddlers, we're going to expect some sort of iron deficient anemia only because they're picky, picky, picky eaters, right? They're going to eat their chicken nuggets, macaroni and cheese, their apple juice, no green leafy vegetables for them, right? So again, that could be part of it. With immunological, we're going to see things like frequent infections, sore throats, colds, pneumonias, whatever. We're going to see something going on that's going to give us some clues. And of course, any bleeding. And bleeding could be ecchymosis, petechial rash, etc. Okay. So anemia, as I said, most common hematologic disorder of children, and we know it's all about the iron. So we're not getting oxygen and we're not getting iron to the body. Red blood cells, when you don't have enough, you're not going to be able to have that energy or you're not going to have the oxygen to do things you need, right? So you're not being fed what you need. So sometimes iron deficient anemia or low blood counts, you need to know basically the numbers. In children, we say it's about 10. We call it iron deficient or low hemoglobin. But in infants, it's not uncommon to be a little bit lower, about 6 months old. Remember, they have not started to make their own red blood cells yet. And normal cells just die off normally. So their count's getting lower and lower. But as getting into toddlers and older, they should have a minimum of 10 as a hemoglobin. Now, anemia, why is this a big deal? Besides no iron, no oxygen. Well, the cells in the blood vessels tend to hold it together and it's a constant swoosh. When you don't have enough cells, they sort of bounce off of each other. And one of the most interesting things is you get a child in complaining of being tired, looking pale, no energy, all that good stuff. Listen to their heart sounds, and you will definitely hear a murmur. You'll hear that. It's like a movement of cells in the blood system. And it's not like cha-chung, 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 normal blood heart rate, right? You hear that. It's very much a flowing thing. So you don't have enough blood, hemoglobin in there. You can have this good old murmur going on. You don't have oxygen. What's the heart going to do? It's trying to help, isn't it? It's going to try to beat faster. It's going to try to get that blood around, try to get that oxygen around. So you're going to go into failure if it continues with low blood counts, all right? And we know you don't have oxygen, you don't have food or iron, there's going to be some form of growth retardation. Now, we've talked about iron deficient anemia. That's nutritional, right? We also have B12, intrinsic factor. That's one of them, right? Another one we can have with decreased blood cell production is something called bone marrow failure. Your bone marrow produces cells. Well, in aplastic anemia, it's almost like a leukemia and treatment, etc. We're going to go into it more, but the cells are just being destroyed. And this is red blood cells. This is white blood cells. This is platelets. Aplastic anemia is everything. Very similar to ALL. And we'll go into why all those things. Now, acute blood loss. Well, we do have times where we bleed. It could be a nosebleed, or it could be some sort of condition. Hemophilia, factor 8, factor 9, von Willebrand's. These are all, they're conditions that have something of that clotting cascade. It's missing, so it doesn't clot properly, okay? So one of the other ones is called ITP. Now, ITP, you need to know this one, is idiopathic thrombocytopenia purpura. P, platelets, decreased platelets. What do you know about decreased platelets? No platelets, you're going to bleed. What signs and symptoms will you see if you have low platelets and your tendency to bleed? Nosebleeds, petechiae, ecchymosis. These is ITP. And we're going to go into when that happens and what to take care of it in a second. Then we have increased red blood cell production, but it's, the destruction, it just, these cells, they're born and they're destroyed. One of the biggest ones is, and we've heard of it, sickle cell anemia. These are sickle-shaped cells that are made and they die quickly. So again, big, low hemoglobin hematocrits because of this destruction. The other one that we see is thalassemia. So sickle cell is sickle-shaped cells that die quickly. Thalassemia, I call them rectangular shaped cells, and they explode, putting iron into the system. So now you're in iron overload, okay? That's thalassemia. And then, of course, we have destruction by things like giving leukemia, giving the chemotherapy, drugs, etc. It could be infection. So again, types of anemias. So how do we handle your anemia? Again, history physical. Find out what's going on. Child's tired, this and that. It's been progressing since whatever. Do that simple CBC. Look at white cells, red blood cells. Let's look at platelets. What's going on there? Neutrophils, tell me what's their infection. And then again, treating anemia and treating the symptoms does not take care of why do you have anemia. Okay, so treat the cause. What is the cause? Is it nutritional, or is there sickle cell or thalassemia? What do we need to do for this child? Okay, so you get a kid in, they've got a low hemoglobin hematocrit. Number one, we need to support that volume. We need to give some fluids, and they're saying to give oxygen. Now, I want to tell you that's sort of controversial. If you don't have red blood cells, how are you going to carry oxygen? But I guess the oxygen, it maximizes what you can have, but it's the most important thing is bed rest, making that child not burn any extra energy because they don't have any, okay? So looking at a kid, how old are they? Their racial ethnic background can tell you what's going on. Sickle cell is African Americans, thalassemia is off the Mediterranean Sea people. So there's little key clues that we could get just from understanding that. And then let's just rule out, is it a GI bleed? Don't assume it's anemia of any sort. Rule out. is it a bleed? So they always do an occult blood. Again, whatever you're doing on that child, you prepare them. You try to decrease their stress, which is their consumption of their oxygen and getting them restless, right? So keep them as calm as we can. So iron deficient anemia. It's not enough iron. And we know, as I just said, this is your toddlers. They just don't like to eat that good old broccoli. I mean, I was very blessed with Christian. You'd give him a plate of broccoli and he'd eat the whole thing before he'd eat many other things. But not all kids are like that. They just want what they want. So again, toddlers are that. Also, have you ever wondered why we give iron fortified formula, iron fortified cereals to infants at 6 months? It's because they're burning off all of their iron. Their cells are not as strong. Remember, their hemoglobin hematocrit drops significantly in the middle of infancy because you haven't started yet to make your own red blood cells, and mommy's red blood cells are going away. So we give iron to give the most strength we can for that child. And this milk babies is giving baby just whole milk without iron fortified. Again, you're being iron deficient because of that. And that's what that's talking about. So how do we fix iron deficiency anemia? Well, we're going to fix that by diet. And then if we need to, iron supplementation. Now, you need to know how to give iron to an infant. And that would be, or a young child. And let's say it's the liquid. Now, if you've ever seen iron liquid, it's brown and it will stain your teeth. So you need to give it in a straw so it protects the teeth. Also, iron is metabolized in the stomach by stomach acid. So it needs to be given on an empty stomach, and it's even best with orange juice. That acid helps break it down. No milk, no food, empty stomach, orange juice through a straw. And please tell that parent that that stool on that child is going to become almost black. And it is almost black from iron, okay? Now, sickle cell anemia, it is hereditary. If both parents have a trait, not the disease, trait, 25% that their child will have a disease. Okay, so there's 1 out of 4 chance there. So let's look at what sickle cell is. Now, sickle cell is all about the shape of cells, and it's all about the size of blood vessels. The blood vessels shrink and get small. Those sickle-shaped cells are going to get stuck at usually a bifurcation of a blood vessel. It gets stuck. And then cells behind it back up, and then it swells, becomes painful, and distally becomes numb because there's no blood flow going down there. And it's all due to the blood vessel wasn't big enough for these blood cells to go through. So how do you think we treat it? Well, what causes sickle cell, these crises to happen? Anything that causes blood vessels to get smaller, trauma, swelling, right? Infection, fever, dehydration, not giving fluids. Stress will always cause anything on autoimmune problems. And again, any dehydration will cause that hypoxemia. So we need to get those blood vessels big. We need to dilate them with heat. We need to get that blood flowing through so we decrease that block up and all of that pain. So priority treatment, hydrate, hydrate, hydrate. Now you're going to say this really hurts. Yes, it does. Priority, IV fluids, and the other hand is my pain medicine at the same time, okay? Another thing we do look at is electrolyte replacement. They have problems with their potassiums. And another thing about sickle cell, I've taken care of quite a few young children, teenage children, sickle cell. And always, when they come in a sickle cell crisis, you'd be surprised what their hemoglobin and hematocrits will be. If they are above 6, I'm happy. I've seen 4, 5, and 6 hemoglobins, which means I'm immediately given blood down in the emergency room. Their blood cells die so quickly that their hemoglobin hematocrits go very, very low. So not only you're in pain and this swelling, you're exhausted because you don't have any, energy at all because your hemoglobin hematocrits are so low. So it's a really uncomfortable time for these children. Most of the time, these sickle cell crises can be due to infection. Any autoimmune patient with a fever of 100.5 and higher needs to call the doctor immediately to be placed on antibiotics. It's prophylactic. Get a fever, antibiotics. These children cannot mess with it. Another thing we do for children is the young ones to protect them is we do give them one penicillin a day, and that's prophylactic to try to help prevent infections on these children. Yes, we'll be doing retic counts. We want to see if they're making any blood by themselves and what does it look like. And of course, blood transfusions will be given. Now, blood transfusion replaces that oxygen right away and gives them what they need to get that energy back. So that's why we give it, and that's for the ischemia. Now, sickle cell, there's no cure. I have seen bone marrow transplants to try to help it. Some work, some don't. I mean, that's with any transplant. Again, sickle cell, it's all about being immunocompromised, and it's also about trying to keep that child, washing hands and infection control and being very aware of it because they do get infections quickly. They're taught you get that little fever, get intervention now. If they're on that penicillin, make sure they take it. Another thing we don't think about is sickle cells in the brain. It's a stroke, isn't it? That means it's clogged off. That means blood's not getting somewhere. So it could be a stroke. So look for those signs and symptoms. It's not just like in a leg or an elbow or a knee, right? This is the brain. This could be serious. Also, it could present like pulmonary embolus, okay? Because you have blood vessels in your lungs also. These children, the prevention is the whole big thing. How do we prevent sickle cell issues in children? Keep them hydrated. If it's cold outside, have them in warm clothing so they don't get constricted, so blood flow can continue to go, right? They even say going up in an airplane, make sure you overhydrate, get those blood vessels bigger because they will constrict up on the plane. It's all about keeping the blood vessels big through heat, through fluids. Now, thalassemia, as I said, is really similar to sickle cell in a way. It's a cell that's not shaped right that dies quickly. These are what I call the rectangular shaped cells. Now, this is usually, as I said, descendants of people living near the Mediterranean Sea. That's what they say about thalassemia. There's 4 types. You don't have to know the types. What we usually describe as thalassemia is Cooley's anemia, which is the very severe of all of the thalassemias. Now, thalassemia, the blood is born, they make it normally, but it's formed irregularly. And immediately, quickly, these cells die. So constantly, we give a blood transfusion and we get their hemoglobin hematocrit up. Then their cells die and it's low. So you have high hemoglobin, low hemoglobin, high hemoglobin, up and down with your transfusions, and then the die and transfusions. This is really going to mess havoc with your heart failure, because when the hemoglobin drops, what does the body do? It beats quicker. It wants to really try to get oxygen around our cells, but there is none, okay? So how do we diagnose thalassemia? Well, it's usually not at birth. They don't see it. But remember, as they're getting older, we're going to be checking their CBC because we know it's going to drop. We want to make sure it doesn't go too low, right? Well, as we're looking at it, right about 6 weeks of age, that's when we start to see the changing of shapes, and that's when we can diagnose it. What is the treatment and what is our concern about thalassemia? Number 1, they must live on blood transfusions. So it's all the things with blood transfusions, reactions, et cetera, et cetera. The other thing is these blood cells, these red blood cells have iron in it. and they explode, purging all that iron into your blood system, and it becomes toxic, believe it or not, toxic. So you either take oral type of iron chelating drugs, and it's called defoxamine or desferril, or you can actually go on this machine called apheresis. It's very similar to your dialysis, but it only takes a component off of blood. So again, these are things that we would do to treat it, to look at blood transfusion and iron, making sure it doesn't become toxic. So thalassemia, they can live as long as they're getting all their blood transfusions and following up well. They usually die from heart disease. As I said, their heart's beating fast and it's fine, and heart's beating fast when the hemoglobin goes down, and then you get blood and now they're okay. So that up and down, really, the heart doesn't like it. And again, they usually will try to take the spleen out to stop these blood cells from being formed, and then it's the sepsis and organ failure with it. Now, I mentioned aplastic anemia already, and when we talk about it, we're going to talk about pancocytopenia. All components of the blood are depressed. What components are we worried about? Hemoglobin, hematocrit, white blood cells, and platelets. So, white blood cells are decreased. You're going to get infections. Hemoglobin, hematocrit are lower. You're going to be tired. You're going to have, needing transfusions. Thrombocytopenia, low platelets. You're going to have bleeding, petechiae, ecchymosis. You might need platelet transfusions, right? We treat this child very similar to leukemia. We give immunosuppressive therapy. We might do a bone marrow, but chemotherapies and whatnot to try to get rid of this cancer that's causing problem, this anemia. Now, blood clotting, hemophilia, child who gets cut and bleeds and it doesn't stop. It is X-linked related recessive. Mommy gives the baby, the child, hemophilia. X-linked recessive. These are the three types of hemophilia. And why are there different types? Well, if you look at what clots blood, it's many different things, many different factors, your platelets and other stuff, right? So when you don't have that factor 8, it's called hemophilia A. That's the most normal of all of them. Then if you have factor 8 but are missing factor 9, it's Christmas disease or hemophilia B. And then there's another one called von Willebrand's disease. And it's the factor, it's called von Willebrand. I guess it's the scientist who found it, and factor 8. So hemophilia, once you have it, you have it. There's no cure, but we need to treat it. So what do we see with children with hemophilia? Well, these kids are going to be bruising, they're going to be bleeding. Also, they're going to be falling maybe on their elbow or on their knee, and their knee or elbow is just going to blow up, with all this bleeding inside the joint, with hemoarthrosis, ecchymosis, right? So bring the child in. We need to check it. Is this child hemophilia? What's going on? What's the bleeding problem? So specifically, we will go and we will draw the factors. They take about a week for a special lab to get them back to you. So not telling you anything quickly. So how will we know maybe it's hemophilia? Your PTT, that's that heparin thing that we look for, PTT, is really long. I think the high level is like 40. It could be 400. So prolonged PTT, platelets are normal, and these other levels that have to do with bleeding, they're all normal. So if we see prolonged PTT, they're not on heparin or anything, something's going on, you can probably say it's hemophilia, and then find out if it's 8, 9, von Willebrand's, and then they can treat it completely. So kid falls down, and he's hurt himself. He's hit his knee, and it's swelling, and it's painful. What do you do? Well, patients are taught how to give this at home. There's some IV, there's some intranasal, but the one thing that we do give is the factor. Now, I tell this story about this little 8-year-old boy and father. 8 or 9 year old little boy. He came into the ER one Saturday with his father, and he had hemophilia and hemophilia 8, factor 8. And he had fallen down and his knee was swollen and it was bruising and it was painful. And they couldn't get a hold of his endocrinologist, or hematologist. So they came in to say, do we need to give it? Well, our physician said, yes, go ahead and give it. Well, the father had brought in his own factor 8 and all of his own equipment. And he asked me, can I give my own stuff? Sure, why not? I watched this father give this child an IV infusion of factor 8. The boy picked the vein out. It was a butterfly. This father washed his hands, set things up, used alcohol, pulled it up, did it as well as any person could do. And then the son said, this vein, the dad got it in. He held the butterfly. The father pushed it in. It was the most amazing thing I've ever seen. The kid wasn't screaming, yelling, and upset. The father did it well. And I had an orientee with me who was like, wow, that was beautiful. Yes, it can be done very, very well. And these people can really handle their child at home. So our care hemophilia is all about you fall down, you hurt yourself. We're going to do just like a sprain, which is basically rest, ice, compress, and elevate, right? And what that's going to try to do is pressure, constrict, and try to stop the bleeding. When we're doing that, then you're probably going to need the factor at home. And again, that can be given. Now, some children aren't diagnosed till, maybe in their toddlers. Remember the P, the protect. This is something, again, a safety question. What would you do to protect a child, let's say a toddler, in the house who's been diagnosed with hemophilia? What's your concern? Falling, scraping against something, bleeding? How about sharp edges on coffee tables or things that could cause them to bump into, cause them bleeding, or an abrasion or a laceration? So you need to go around, put bumper pads wherever it needs to be for that child so that we're not going to let the kid bleed at home. Okay. So protect the house. You know, children can live and into adults with being hemophiliac. Yes, they're working on genes, to cure it. We're pretty close to something coming up already. But the one thing I want to remember about hemophilia is the problem that causes issue is that if they have a fall in a knee, an elbow, a finger, or wherever, a toe, if they don't stop the bleeding and that blood goes into the joint, what it does, it disintegrates it. It makes it, the joint integrity is ruined. And now you don't have joints. And now you're going to end up in wheelchairs and etc. So if we are teaching, making sure if they're bleeding to get it corrected quick to protect joints. And we can do that. Again, it's teaching them how to do these things at home. So ITP, immune thrombocytopenia purpura, ITP. P for platelets, purpura, platelets. This is bleeding because of decreased platelets. ITP platelets, okay? Platelets, what do you see? Well, you need platelets to have bleeding stop, so what are you going to see? Thrombocytopenia, that's the name of low platelets, and usually less than 20,000. It should be well over 100,000. And then you're going to see purpura, discolored purple things, and petechiae and ecchymosis and all those. Sometimes, believe it or not, it's a nosebleed, epistaxis, that alerts us that it's ITP that's going on. Again, epistaxis, nosebleeds, is bleeding, right? So how do we get ITP? It's something that usually it's an acute stage. It doesn't last, although it can. What it does is following some sort of upper respiratory viral infection. Somehow it affects the platelets and it causes them not to produce, and you'll have low platelet infections. Usually, if we can treat it, and we treat it with IVIG and anti-D, and if we can get that under control, it's going to be gone. And after 1 year, it's still there. It's going to be a chronic condition that we're going to have to maintain and monitor those platelet counts. Now, you get a child going to the ER. going to be admitted to your floor, and that child has a new diagnosis of ITP. What are you, as a nurse, going to do? Well, what's the big issue? It's all about bleeding, isn't it? So we have to protect them from bleeding. So we're going to teach them, like a young adolescent, don't shave your legs, or a young man, don't shaving, because no razors, because they can bleed very easily, right? Along with that, we're not going to give them any IM, sub-Q, any injections. If all possible, we're going to give it IV if there's an IV there, right? And we're going to look at that child. Are they bleeding? Nose, mouth, teeth, urine, stool, looking for any ecchymotic or anything areas. And then in the hospital, we're going to be monitoring a CBC. Remember, the CBC has a platelet count. Is the treatment working? Is the IVIG, anti-D, is it working? Are the platelet counts coming up? That's what we're looking for. And it says sometimes corticosteroids, they give corticosteroids. That is the treatment for ITP. So epistaxis, this is one of your NCLEX questions that you're going to be getting. But I'm telling you, epistaxis does tell us a lot of things. If it's just one, it's not a big deal. That's just a normal happenstance. But if we are seeing more than one epistaxis back to back, there must be a reason why. So what we're going to be looking for, leukemia, thrombocytopenia, and any bleeding coagulopathy we're going to be looking for. So you have a child. Think about it as, let's say, a preschooler. They're bleeding out of their nose, blood everywhere. Do you know what a preschooler is going to do when they see blood? I'm going to die. I'm bleeding everywhere. And they're going to go bonkers. So, first thing, calm the child down. That will decrease the heart rate. That will decrease the blood pressure. That will decrease bleeding, right? Take your finger and your thumb, pinch the bridge of the nose, hold it for 10 minutes. And if you see it, you lean forward. Why do you lean forward? So that you don't swallow it. Let the blood come out if you need to. And if after 10 minutes is still bleeding, get to the ER. Now, some of the immune things, HIV and AIDS. So HIV and AIDS, usually we're talking about, because we're pediatrics, we're talking about the mother transferring it off onto the newborn baby, right? So there is treatment that we can give that pregnant mother about 22 weeks, and then immediately after birth, we're going to be giving these highly active antiretroviral therapy, antivirals, whatever it is. Why do we give these therapies to this newborn baby? Well, we want to take that immune system and make it the best we can possibly do. Okay. The other way, HIV, AIDS, and we talk about adolescents, and it's that risky behavior. And again, we can teach and try to help that. So again, HIV, AIDS, the whole big thing is to boost that immune system of that infant. I have seen HIV positive triplets born from an HIV positive mother, triplets. One had HIV, one had AIDS, and one had nothing. So in triplets, there was all three different outcomes with it. I've also seen HIV positive born babies convert by 1 year old with this therapy. So it can convert. So just to let you know that. Blood transfusions, packed red blood cells, platelets, all of these things are anything that can cause a blood transfusion reaction. Always know what is your hospital procedure on how to give it, and just follow it all the time. Apheresis, I've mentioned it. I've mentioned that, when we talk about pulling off one component out of the blood, and that's actually done by nursing. Bone marrow aspiration. Why would we do a bone marrow looking at hematologic and immunological disorders? We want to look at cells, don't we? What do they look like? Are they healthy? Are they cancerous? How many do I have? What's their shape? All of this stuff, right? Now, Has anybody ever seen a bone marrow aspiration done? Whether it's in the chest, whether it's in the hip, it's quite intense. So what they do is, you'll position your child, like maybe that picture on the bottom on the side, and that's going into the iliac crest of the hip bone. They'll numb it. They'll go down and they'll numb it a little bit with lidocaine. But there is that blue thing, and on it, end of it, is a big, thick needle. They take and put it in and go into the bone, and you hear it. And I think that's the scariest part of all of this about bone marrow. And it hurts. Okay. No matter how much numbing and stuff. Again, with kids, be honest. Let them know it's going to hurt, but you're going to do everything possible to make it as little as possible. And you want me to hold your hand, right? So if both parents have sickle cell, how many is it each of their kids going to have it? What do you think? Each parent has a trait. 1 out of 4. Yes, Aaron. 25%. So children with cancer. I think this is probably one of the hardest areas in nursing to work in pediatric cancer. You all are becoming new nurses, and let me tell you something about pediatric oncology care. There are right now many different hospitals around the country giving $25,000 sign-on bonuses to come on for 1 year or 2 years if you have chemo pediatric experience. It can be really good. Okay. So I'm just saying it's hard to have children get cancer. Some of them die. Yes, they do. But you know something? I've always looked at it this way. I worked cardiac ICU for years. My love, my love, my love. Many of them did die. But it's not that any child died. It's what did you as a nurse do for the child and the family when they were living? And I'm telling you, I've got beautiful memories. I still have parents reaching out to me, and their children did die. It's just that what did you do for them? So you are a major component in that kid's care. So neoplasm disorders, leukemia, and lymphomas. Leukemia. Leukemia is what? It's all about that white blood cells, right? Look at the Down syndrome children again. So Down syndrome, they're cardiac problems, right? They've got a higher risk for leukemia here. So this is a child, Downs, and the thing is, they're very misunderstood. Down's kid comes in and you see bruising on them, and you think it's just because they're clumsy and they're falling down, and you don't think it could be leukemia. Because leukemia, one of the signs is all of their blood components are being eaten up by cancer, white blood cells, red blood cells, platelets. So they're going to be bleeding in ecchymotic areas. So a Down's child might be overlooked. Leukemia is what we call the unrestricted proliferation of immature white blood cells in the blood forming tissue. So what does it mean? Your white blood cells don't work. You don't have white blood cells. What's going to go on? You're going to get infections. You're going to get really septic and sick, right? So, how do you diagnose leukemia? Well, history, physical. I think that this is described as my next door neighbor who was diagnosed with leukemia. She was a teenager, which is unusual. Usually it's younger. But she started with flu-like symptoms, weak, tired, bruising, knee pain, fever, just ick. And the parents are like, this is not the kid. Brought her to the emergency room where I worked. They did a blood smear, CBC, and she had an initial white blood cell count of 0.1. The normal, 7 to 10. So you can see 0.1. Absolutely no immune system at all. So what do we do when we figure this all out now? Well, we're going to do that blood smear. We're going to look what's going on. Remember, cancer doesn't care what it eats. It's going to eat white blood cells, red blood cells, platelets. Everything is going to be there. So they're going to be infected. They're going to be bleeding. They're going to be anemic. This is leukemia. It's a big thing. So again, we're going to do that bone marrow. We want to look at those cells. What's going on? What do they look like? And to make up the plan. Again, be honest with them. Now, once we determine it's leukemia, and we've done, looked at the central nervous system, making sure it's not all up in there and done all of those things, we're going to be starting chemotherapy. They'll put in some sort of central line because we don't want to stick needles in every time they come. So usually it's a port underneath the skin, usually somewhere in the upper chest. And what we do is 4 stages. What you need to know is induction. Believe it or not, induction is the 4 to 6 weeks intense chemotherapy. And the goal is remission. So you're saying there's 3 more steps, right? Well, we're making sure there's no cells hidden anywhere. Is it in the central nervous system? Is it somewhere where they're hiding somewhere where we need to give a little bit of maintenance, something to keep it away? But the induction is achieving remission. And then it's then making sure we're staying there. Now, sometimes with leukemia, we need to do a hematopoietic stem cell transplant because chemo and that stuff's not working. So we can give what we call this stem cell. So there's 2 types. You have mine and everybody else's. So mine, what would that be? This would be those umbilical cord blood that you would save at birth. It has all the stem cells in it, right? We could transfuse that back to that child and they would be getting the good blood cells before it changed to the cancer, right? So that is automatically the best choice. That is autologous. Now, siblings are the best after that with the same parents, but anybody can be a donor. Doesn't matter blood type. It's not A positive, A negative, O. No, they're all the same. Now, the best is automatically mine, autologous, my own. But if I can't, all the others, allogenic, we can give any of them. But the best one from there is siblings of the same parents, okay? So leukemia is big and it's long and it's multiple years long and it starts and it's intense and it's scary, okay? Know that you need to prepare, especially a child who's understanding. Let them know what's going on. Keep them comfortable. Don't think that, oh, they're going to get addicted to pain medicine. They hurt. Keep them comfortable. Let them have a better memory than just pain and feeling horrible, okay? Because they do. And many of them, most of them can come through this out the other side and be just fine. Biggest complication. And why? Infection. They have no white blood cells. Hemorrhage. They do not have any platelets. They're going to bleed. Anemia. Hemoglobin hematocrit going to be low because it's eating those cells too. And again, you're going to be using chemo. You always have to use those precautions. As I said, leukemia is really, we can treat it well. The things that determine outcomes and sometimes even the length of what we have to do, the time. But what was that white blood cell count? Was it 0.1 or was it 0.01 when they came in? And I've seen that one too. That means 10 white blood cells. It's like, I don't know how they're holding their head up and they're not overwhelming septic at the moment. How old were they? The young kids do really good. The 2 and 3-year-olds, believe it or not. And then it's the type of cell. There's ALL and AML. So there's lymphocytes and monocytes. So ALL is easier to cure than AML, to let you know. Boys and girls. Girls are easier than boys, believe it or not. And then what's a karyotype? Remember, they're eating all the blood cells, red blood cells, platelets. They're going to be giving transfusions. Karyotype, are you A negative? Are you this weird blood type? Or are you a blood type that you can get almost blood for whenever? You've got a very hard blood type to do. You're going to be delayed in getting these products, and it could affect the outcome. So chemo, how do we treat it? There's all different ways, isn't there? We can do surgery, or we can do chemo radiation, shrink it and do surgery, or we can do only chemo, only radiation. There's all different types. And again, it's whatever the up-to-date thing is we're going to be doing. Again, cancer is treating it as soon as we can, and these are all the symptoms that my next door neighbor had: pain, fever, ecchymosis, petechiae, bleeding, lethargy, weight loss. I mean, she just felt horrible, as you can see. And then let's look at giving now the treatment. So you've got low white blood cells, you've got low hematocrit, you've got low platelets. So you're really starting in the weakened stage. Um, the biggest concern is of infection, because there is no white cells in there to fight infection. So how do we monitor infection and white blood cells in children? Now, especially in a leukemia, is looking at the neutrophil count. Now, during us giving this chemo and this induction period, we're going to be putting these children and killing so many cells, we're going to get those neutrophil counts down on the floor. They're going to be very low. 500 is almost nothing. Usually they're like 2,000. So that's very low. So this is the child that's going to, let's say they get a fever and they have a white count, they have their neutrophil count of 500. This is the child that's going to end up in the ICU, crash and burn, and go into septic shock. Neutrophil counts that low, there's no system to fight anything in that body, okay? Whether it's chemo, whether it's anything. Neutrophil count low, fever, you're in trouble. So again, making sure we check the treatments, giving antibiotics as we needed. Again, a child with leukemia with a fever, priority, antibiotic now. Hemorrhage is going to happen because of those platelets. So again, making sure you protect that child. That anemia, that means there's no iron, there's no oxygen, that child's going to tire out. Doing reserve their energy. They're going to be nauseous and vomiting with the chemo, right? Do you know when I started nursing, I couldn't give an anti-nausea drug until they vomited, which now we've realized that, like with chemo, let's give it before they're going to vomit to prevent it, right? It makes sense, and we know that works. We know with chemo, their mouths get all excoriated. Mouth to anus could be all with blisters and mucosal stuff. So again, know that we do need some good nutrition on these children. So how do we get the best nutrition? We'll give them a little bit of everything: high protein, high calorie, high fat. Give them whatever they want. The biggest bang for the buck, I call it. If you want to give them something, give them stuff with the most protein, calorie, and fat. So I said their mouths are going to be horrible, maybe using some mouthwashes and maybe some sitz baths for, they might have some sort of rectal lesions there. Again, remember, they can have a stroke, with this one, so be careful. Um, their bleeding is prolonged. If they bear down to stool, they can bust a hemorrhage, a vein in their head, right? So again, making sure stool softeners, keeping their bowels moving. Again, all of these things we have to think about. They can have blood in the urine, just watch for it. And I think the one thing we think of chemo is about losing the hair, right? I used to see how many fathers and brothers and uncles and grandpas would cut their hair for their daughter or their son. I would make bows for the girls, and I'd put one in my hair and one in their hair, or no hair, and we would be matching twins for the day. And it didn't seem so bad for that kid that had no hair. And of course, they're getting steroids, and we always worry about that, especially when you get to adolescence identity, that big round moon face and stuff from steroids. Again, be cognizant, make sure that they have clothes that fit properly. Again, for procedures, explain it to them on their level, right? Doing everything you can do to decrease the amount of pain for them and being honest with them. Pain management, don't not give pain medicine because you think that, it's morphine. Oh my God, they're going to get addicted. These kids really, really hurt. And it's not just pain medicine. It could be a hot pack, a cold pack, could be positioning, could be a hug. There's so many things you can do to help for pain with pain medicine and other stuff. These children with cancer still need a lot of basic care. And one of the things we'll think of is immunizations. They're immunosuppressed, right? They don't have a white count. So we cannot give any live vaccines. Varicella is one of them. We're not going to do that. We can do the ones that are inactivated. They're not live. You can do that. The family, you have to be careful. Some they can get, some they can't. Again, we need to ask questions before we get immunizations to family because of the child. Okay, I want to describe to you two types of lymphomas, and I know 50% will get this question wrong on the exam. There's Hodgkin's lymphoma, you will, and there's non-Hodgkin's lymphoma. They're both cancers, and they're all about lymph nodes. Hodgkin's lymphoma is from the shoulders up. Big things, lymph nodes sticking out. Do you see the picture of those necks? Those are lymph nodes. You can touch them. The thing about it, they don't hurt, but they're big and it starts to occlude the airway and it starts to coughing. And that's usually why parents will bring these kids in. So they have cough. Now it's pushing over. Now you're starting to see these signs and symptoms, fever, anorexia, weight loss, and all that stuff. So you've got this big thing. This, you can feel it, you can touch it. So we need to find out if it is a cancer, and they will do a biopsy. In the biopsy, they find these cells called Sternberg Reed. It's just cancer cells that they'll see, and that they named it that. And of course, we'll be doing all sorts of other lab tests to look for infection and inflammation. And that's the CRP and ESR inflammation, CBC looking infection. Now, Hodgkin disease, painless node sitting there, you can see it. They give it radiation. They'll put a mark on it. This purple mark. Do not ever erase that purple mark because they have to radiate there all the time, okay? Sometimes they'll also do chemo with it. So now we've shrunk up these things and hopefully that will be fine, all right? So one of the things about Hodgkin's disease is because of the chemo radiation, you're at high risk for infertility with this one, okay? So Hodgkin's is a big above the shoulder. You can see it, feel it, touch it. It's a house, it's a lodge, it's a Hodge. Non-Hodgkin's lymphoma, you can't feel it. It's diffuse. So, and the other tiny little lymph nodes, the armpits and the groin and the abdomen, but you know this big thing and it's not above the shoulders. Hodgkin's, I can feel it, I can touch it, okay? It's not painful. Non-Hodgkin's, it's all over, I can't touch it. And that's the difference. Treatment is just about the same, okay? Now, nervous system tumors. So let's talk about some brain tumors, right? So in children, you've got a child, all of a sudden their head starts to get bigger, hydrocephalus, or they're getting headaches that are getting worse over time. Vomiting, not related to eating. Then you might see the eyes that wiggling back and forth, nystagmus. You've got a tumor in the head, right? So now it's affecting your brain. Now you're going to start with that weird walk, ataxia, movement. I can't control it. Dysarthria. It could even go in and attack the pituitary gland, which is diabetes insipidus. And the other side of the pituitary gland, which is all about growth. Okay? So what do we do? Of course, signs, symptoms, do x-ray. We're going to go through. We will not, with a brain tumor, do a lumbar puncture. It's because that brain tumor is pushing the fluid in the head and it's pushing it down the spinal column, your cerebral spinal fluid. If you put a needle in it, it's going to squirt and it's going to dislodge the brain. It can cause a lot of problems. So brain tumors, how do we treat it? Well, depending on where it is, we're going to number one, probably shrink it, radiation, chemo, and do surgery to get it out. We will, if we can, depending on where it is. All right. Now, post-op brain tumors, brain surgery, there's a lot of things that can go on. So, number one, positioning. Can I have the head of the bed elevated, or is it should be flat? Can I turn them to that side of surgery of the brain tumor or the other side? All of these things we need to look for. And a big thing is fluid regulation. You do not want to overhydrate these children at all. Now, neuroblastoma, this is a tumor that starts in the tummy and it gets big and it takes over the abdomen, but it metastasizes to the brain and it's already there before you even know it. And that's all you need to know. Before you know it, it's already throughout the body, in the brain and in the abdomen. You know, it's something that the outcome's not great. They tried to do all chemo, radiation surgeries, but not always is it successful. Bone tumors. What do you see with bone tumors? Well, usually with bone tumors, you'll see all of a sudden a limp, a pain, something going on that progressively is getting worse. That, maybe, you start limping and something's wrong there. Sometimes you can feel something, sometimes not. Sometimes you have a fever, sometimes not. So all of them are a little bit different. Now, when we talk about bone tumors, we're going to talk about osteosarcoma, which is a bone tumor. How do we diagnose it? Well, mother comes in, the kid's complaining of pain and limping, right? And I feel this little knot here. What's going on? So again, going to do that x-ray. We're going to do lab results, find out. It's a cancer. Is there weight loss? Have they been having infections? Remember, their immune system's going to be beat up a little bit with this cancer. This osteosarcoma, most of the time, we think of it as a femur bone osteosarcoma. This is a lot of times adolescents, and a lot of times these are adolescent boys. And what it is they start with pain in their knee that gets progressively worse. They go and they do an x-ray and they find this fuzzy on it and they find it as cancer of the bone. What do they have to do? Well, that femur bone, complete femur bone, is infected with cancer. It has to be removed. But instead of leaving no leg, no nothing there, they take the lower leg, the tibia and the fibula, and they put it up into the hip bone to create a area where you can put a prosthesis. And if you look at that bottom picture, they turn it around so that they can fit that prosthesis so they can walk and be more agile and mobile by themselves. Osteosarcoma, it's a big thing. Wilms tumor, we'll mention this about twice because this is also GU. Wilms tumor is a kidney tumor, and it's usually little boys. Usually you're 3 to 5 age, and all of a sudden you'll feel like a little something in their belly. I've seen only one of these in my career, and it was a little boy who came from Haiti. And he came in with this religious group who knew nothing about him, and all of his papers were in French. So I didn't know why he was coming to the emergency room. So I had to do an assessment, head to toe. And when I was doing an abdominal assessment, his left lower quadrant, this big, was a mass in his lower belly. And for some reason, I knew it was a Wilms tumor. So, Wilms tumor, it's this tumor, very fragile, and it does break off and metastasize on manipulation. This is something you are going to leave it alone. Don't touch it. This is something you're not even going to do a biopsy before surgery because you don't want that little hole putting metastasis in the abdominal cavity, okay? So we're going to go do radiation, maybe chemo, we'll do surgery, and we're going to take it out. And that's the type of incision. It's a big open incision because the kidneys are in the back. You have to go through the abdomen, through all the intestines to go back into that kidney. So preoperatively, do not palpate abdomen. That's your biggest nursing care. All right. And then postoperatively, you're going to monitor their urine and their bowel function. A retinoblastoma, cancer of the eyeball. Ever see a cat out in the dark, or a dog or an animal, and you see those shiny white eyes? It's called a cat's glow or cat's eye. And that's telling us there's a tumor in there. I've seen a little 8-month-old girl. All of a sudden, I saw that eye and I went, "Oh my, what is that one?" And again, we diagnosed her there. How do we take care of this? It's a big thing. It's radiation, it's chemo, it's surgery. You have to take the eye out completely, and then they usually will put prosthesis in there. One of the things with retinoblastomas is, nursing history. It's like, what happened? What were the signs and the symptoms that led up to it? Are they having frequent eye infections or tearing or pain, or just to get to the bottom, why did this go on? Another sort of tumor is germ cell tumor or testicular tumors. We say, breast exams for women. Well, men should be doing testicular exams. I had an 18-year-old boy come into my ER, into the triage area, and the other nurse who was with me took care of him. And this one came in with his mother and his girlfriend, who was pregnant. And he said he was having testicular pain. So the nurse said, "Okay, show me," after she did the assessment. And there was a big softball-sized testicle. And she said, "Oh my." So we sent him to x-ray, ultrasound. This child had been having pain for well over a month. He had already metastasized throughout his entire body, and he actually died 3 months later. So testicular exams, very important. Liver tumors. It is a big deal, but the thing about livers, they grow back. Livers do very well. So cancers today, they say 5-year, 80%. I think it's a lot higher than that now. I know in the years I've been a nurse, it's come up quite a bit. Better treatments as we go. The thing is with cancer is trying to keep that kid as normal as they can be. And, those Facebook pages, that's what I want to see. Cancer free, right? So, Aaron, do you need your 10 minutes? I know you do. You're biting at the bit. I can see. All right, it's 4:03. Come back 4:15, and we'll go with our cahoots. Not a problem.